Bismillahirrahmanirrahim. Assalamu alaikum. Today's lecture is anti-malarial drugs. Most common species of Plasmodium which cause malaria is Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, Plasmodium ovale. Plasmodium ovale, it is mainly confined to Africa. Uh, Malaria is spread by the bite of the female Anopheles mosquito. This is the cycle uh, which is shows how mosquito is involved in the spread of malaria. First of all, at the first step, an infected mosquito injects sporozoites. Next, in the second step, sporozoites migrate to the liver. In the liver, they form merozoites. And in the third step, merozoites are released and invade the red blood cells. In the fourth step, in the red blood cell, the merozoites becomes a trophozoite. In the fifth step, in the red blood cell, the trophozoite multiplies, producing new merozoites. Merozoites are released when the red blood cell ruptures and they can infect other red blood cells. Some merozoites in the sixth step, as shown, some merozoites become gametocytes. Now, in the seventh and final step, the female mosquito picks up gametocytes from an infected human. The sexual cycle occurs in the mosquito where sporozoites are formed. Now the drugs which are effective against exoerythrocytic form of malaria, it is Primaquine as shown in the figure. The drugs which are effective against erythrocytic form, these drugs are artemisinin, chloroquine, mefloquine, and pyrimethamine. The drugs which are effective against gametocytic form is Primaquine. Now one by one I will discuss all these drugs. First of all, I will tell you the classification. Two types of classification. First is chemical based and second is therapeutic classification. In chemical based classification, first group is quinolone derivatives. In quinolone derivatives, further three groups are present: aminoquinolones, quinolone methanols, and quinones. And in aminoquinolones, drugs are included four aminoquinolones, which include chloroquine and hydroxychloroquine, amodiaquine, eight aminoquinolones, which include primaquine. In quinolone methanols, the drugs include quinine and quinidine and mefloquine. In quinones, the drugs include atovaquone. In phenanthrene methanol, the drugs include halofantrine. In aryl alcohol, the drugs include lumefantrine. In the next group, lactone endoperoxides, drugs in this group include artemisinin, which further divide into dihydroartemisinin, it is the reduced products, then artemethyl, it is oil soluble form, and artesunate, which is water soluble form. Next, fifth class is folate antagonists, which include pyrimethamine, trimethoprim, proguanyl, sulfonamides. And the last group is antimicrobials, which include doxycycline and clindamycin. Now the therapeutic classification is shown in the next. According to therapy, they are divided into the following groups. Prophylactics, which is also known as tissue schizonicides. That is these are the drugs that kill the pre-erythrocytic forms of parasites. These drugs are as proguanyl, pyrimethamine, primaquine. And next category, suppressive prophylactics. These drugs are the blood schizonicides. It includes chloroquine, mefloquine, lumefantrine, quinine, pyrimethamine, artemisinin, amodiaquine. It is also used as clinical curatives. Blood schizonicides also called as clinical curatives. Next, terminal prophylactics, which is also known as radical curatives. Hypnozoitocides. Primaquine is the primary drug. It kills the dormant hypnozoites of Plasmodium vivax and Plasmodium ovale in the liver. Please focus on it. It only kills the dormant hypnozoites which are present in the liver. And the next category is gametocytes. They destroy the sexual forms of the parasite. For Plasmodium vivax, the drug is given which is effective against Plasmodium vivax, chloroquine, and quinine. And the drug which is effective against Plasmodium falciparum is primaquine. Now the chloroquine, 4-aminoquinolone, it's the most important drug in antimalarial drugs. And mechanism of action, clinical uses, and adverse effects of drugs are most frequently asked in the exams. It's a potent blood schizonticides. This is shown the mechanism of action of chloroquine. Actually, it happens when the parasite digests the host cell's hemoglobin to obtain essential amino acids. That processes release large amount of heme, which is toxic to the parasite. Now, to protect itself, the parasite ordinarily polymerizes the heme into non-toxic hemozoin, which is sequestered in the parasite's food vacuole. Now, what happens in the fourth step that when chloroquine is given, chloroquine prevents the polymerization of heme to hemozoin. Chloroquine, it tends to accumulate the heme. The accumulation of heme result in lysis of both the parasite and the red blood cell. So I will repeat again, the parasite actually digests the host cell's hemoglobin to obtain essential amino acids. This process releases large amount of heme. That heme is toxic to the parasite. To protect itself, that is the parasite, for the protection of parasite, the parasite polymerizes the heme into non-toxic compound which is known as hemozoin, which is sequestered in the parasite's food vacuole. When chloroquine is given, chloroquine prevents the polymerization of heme into hemozoin. The accumulation of heme results in lysis of both the parasite and the red blood cell. As I already told you, that heme is the toxic product for the parasite. Now, why resistance occur in case of chloroquine? Either there is enhanced efflux from the parasitic vesicule, which is due to increased expression of the human multi-drug resistant transporter, which is that transporter is known as P-glycoprotein, or either there is the mutant heme polymerase enzyme, which inactivate the drug. Now, the clinical uses of chloroquine treatment, it is the drug of choice for acute attack of all uncomplicated non-falciparum malaria and the sensitive P. falciparum, Plasmodium falciparum malaria. Chloroquine phosphate is given in the dose of 600 milligram in the base or 1 gram salt, followed by 300 milligram base or 500 milligram salt at 6, 24, and 48 hours. Total dose of chloroquine equal to 1500 milligram base or 2500 milligram salt. Now the next clinical use is chemoprophylaxis. It is also used in case of chemoprophylaxis in regions with chloroquine sensitive areas. Dose which should be given 300 milligram base or 500 milligram salt per week. It is given 1 week before entering the endemic area and 4 weeks after leaving the area. Prophylactically, it is also given with Primaquine for radical cure. Next, chloroquine has also an anti-amoebic effect. It is used in case of amoebic liver abscess as chloroquine is concentrated in the liver. It is also used as anti-inflammatory agent in certain autoimmune diseases because it has immunomodulatory effect. It is used in diseases like rheumatoid arthritis. Hydroxychloroquine is used in rheumatoid arthritis, discoid lupus erythematosus, and solar urticaria in those individuals sensitive to ultraviolet light. Next, adverse effects of chloroquine. It is well tolerated in therapeutic range in divided doses with no significant adverse effects. Adverse effects include on GIT, anorexia, nausea, vomiting, bitter taste, local irritant effect. In CNS, it may include headache, confusion, psychosis, convulsion, and maybe peripheral neuritis. In CVS, the adverse effects include hypotension, T-wave changes, prolonged QT interval, AV block. Next, on skin, adverse effects include exfoliative dermatitis, urticaria, pruritus, and maculopapular rash. Next, in eye, adverse effects include pigmentation macula, that is the pigmentation may occur on macula of eye, retinal artery stenosis may occur, blurring of vision, visual field impairment, color perception impairment. Melanin containing tissues, chloroquine may deposit in melanin containing tissues resulting in melanin is present in skin. So it may result in hyperpigmentation of nails, pigmentation of skin, and hair changes. On blood, adverse effects is that hemolytic anemia, especially in glucose 6-phosphate dehydrogenase deficient patients. Leukopenia and thrombocytopenia may also noted, but in some cases. Hypersensitivity reaction may also occur. with the use of chloroquine. Chloroquine is considered to be safe for use by pregnant women and young children. As compared to other anti-malaria drugs, it is considered to be safe for use by pregnant women and young children. Next drug is Primaquine, 8-aminoquinolone, as chloroquine is blood schizonticide. Primaquine is tissue schizonticide. It is the drug of choice for the eradication of dormant liver forms of Plasmodium vivax and Plasmodium ovale. So note that it is used for the eradication of dormant liver forms. Exact mechanism of Primaquine is not known. It may affect a cellular level, it inhibits the electron transport mechanism, or it may generate reactive oxygen species within the mitochondria. It also acts as gametocide, so it inhibits infection transmission by mosquito, especially for Plasmodium falciparum. Pharmacokinetics of Primaquine, its three major metabolites appear to have less antimalarial activity, but more potential for inducing hemolysis than the parent compound. Now the clinical uses of Primaquine, it is used as therapy or radical cure of acute vivax and ovale malaria. It is also used as terminal prophylaxis of Plasmodium vivax and Plasmodium ovale malaria. It is also used in case of chemoprophylaxis of malaria. It is also used as gametocidal action against Plasmodium falciparum. Single dose of Primaquine 45 mg base is really effective as gametocidal action against Plasmodium falciparum. And lastly, it is also used in pneumocystis gyrovecta infection. Clindamycin and Primaquine, usually both drugs are given in case of pneumocystis gyrovecta infection. Now, the adverse effects may include GIT upset, headache, pruritus. But the adverse effects are more common with higher dosage and when the drug is taken on empty stomach. Standard drug therapy may cause methemoglobinemia, hemolysis, especially in glucose 6-phosphate dehydrogenase deficient. The rare adverse effects include agranulocytosis, leukocytosis, and arrhythmias. Now the contraindication, it is Primaquine is contraindicated in. Next drug is quinine and quinidine. It is obtained from cinchona bark alkaloid and quinidine is obtained from quinoline methanol. It is blood schizonticide. It is effective against all 4 species of Plasmodium. So note that it is effective against all 4 species and it is blood schizonticide. It is gametocidal for Plasmodium vivax. It is quinidine is a dextrorotatory stereoisomer of quinine and is as potent as quinine but not recommended due to its high toxicity. Quinidine has a shorter half-life than quinine, mostly as a result of decreased protein binding. Mechanism of action of quinine or quinidine is somewhat similar as that of chloroquine in being able to bind heme and prevents its polymerization. Quinine is not so extensively concentrated in the plasmodium while chloroquine has to be trapped inside the food vacuole. Clinical uses of quinine or quinidine, it is used as blood schizonticide against all 4 species of malaria. It is the major use is chloroquine-resistant Plasmodium falciparum malaria. In case of chloroquine-resistant Plasmodium falciparum malaria, it is given in the form of quinine dihydrochloride or quinidine gluconate, either intravenous or intramuscular. It is also used in acute attack of malaria. It is not for prophylaxis it is not used for prophylaxis due to its toxicity. It is act as gametocidal against Plasmodium vivax and Plasmodium ovale. Now the adverse effects are quinidine. Synchronism, therapeutic dosage of quinine and quinidine commonly cause tinnitus, headache, nausea, dizziness, flushing, and visual disturbances. More severe findings often after prolonged therapy include more marked visual and auditory abnormalities, which include vomiting, diarrhea, and abdominal pain. Hypersensitivity reaction may occur with the use of quinine or quinidine, like skin rashes, urticaria, angioedema, and bronchospasm. Hematological abnormalities may occur, hemolysis, especially with glucose 6-phosphate dehydrogenase deficiency, leukopenia, agranulocytosis, and thrombocytopenia. At the injection sites, intermuscular pain and necrosis may occur, and intravenous thrombophlebitis may occur at the injection sites. On CVS, there may be depressed cardiac conduction. There may be severe hypotension, QRS, widening, increase, QT interval may occur. Hypoglycemia may occur with the use of quinine, because it influences the secretion of insulin, so 5% dextrose is really given with IV quinine. It may stimulate uterine contraction in the third trimester, but mild. Black water fever may occur with the use of quinine, and black water fever occur due to intravascular hemolysis. That complication occur due to intravascular hemolysis, but it occur in rare cases. It is appropriate for severe chloroquine-resistant falciparum. It has more adverse effect, so it should be reserved for only severe chloroquine-resistant falciparum in pregnancy. It is usually given with clindamycin and doxycycline to reduce the toxicity and duration of therapy. Next drug is mefloquine, which is quinolone methanols. It is a strong blood schizonticides. It is restricted for use against multi-drug resistance Plasmodium falciparum only. It has same mechanism of action as all quinine. It inhibits heme polymerase. Now the clinical uses, it is effective against multi-drug resistance uncomplicated falciparum malaria. It is effective against chloroquine-resistant malaria, and is also used as chemoprophylaxis. Chemoprophylaxis means for prophylactic, only for prophylactic therapy, not for acute attack. Weekly dose. Only chemoprophylactic other than chloroquine approved for children weighing less than 5 kg and for pregnant women. So chemoprophylaxis, it is used as weekly dose. Adverse effects include most common side effects are nausea, vomiting, dizziness, sleep and behavioral disturbances, epigastric pain, diarrhea, abdominal pain, headache, rash and dizziness. It may provoke neuropsychiatric disorders and seizures like depression, confusion, acute psychosis and seizures. Leukocytosis, thrombocytopenia and aminotransferase elevations have also been reported. Mefloquine can also alter cardiac conduction. Arrhythmias and bradycardia have been reported. Mefloquine is also now considered safe in children, young children, and for pregnant women throughout pregnancy. Next drug is halofantrine. It is phenanthrene methanol. It is blood schizonticides. It is active against strains resistant to chloroquine, pyrimethamine, and quinine. But its mechanism of action is somewhat unknown. Adverse effects include abdominal pain, diarrhea, vomiting, cough, rash, headache, pruritus, and elevated liver enzyme. Dose-related prolongation of QT and PR intervals may occur. There are rare instances of dangerous arrhythmias and deaths which have been reported. Next drug is lumefantrine, which is aryl alcohol. It is available only as fixed dose combination with artemether. So lumefantrine is available in the form of combination with artemether. It is a first-line treatment for uncomplicated Plasmodium falciparum malaria. The half-life of lumefantrine when used in combination is 3 to 4 days. Use is coartem is highly effective in the treatment of falciparum malaria when administered twice daily for 3 days. Adverse effects include gastrointestinal disturbances, headache, dizziness, rash, and pruritus. There may be minor prolongation of the QT interval. Next drugs, antifolates. Actually, it happens that antifolates mechanism of action is shown in these slides. Para-aminobenzoic acid is converted into folate with the help of enzyme dihydropytyrate synthetase. And folate is converted into tetrahydrofolate with the help of enzyme dihydrofolate reductase. And tetrahydrofolate is used in the synthesis of thymidylate and which is used in the synthesis of DNA. So sulfonamides inhibit the dihydropytyrate synthetase. It inhibits the conversion of para-aminobenzoic acid into folic acid by competing with para-aminobenzoic acid. And pyrimethamine inhibits the enzyme dihydrofolic reductase. So type 1 sulfonamides and sulfones which compete with para-aminobenzoic acid, and type 2 pyrimethamine and proguanil which inhibit dihydrofolic reductase enzyme. Combination form is used, and Fansidar there is sulfadoxin, sulfonamide which is 500 mg per tablet, and pyrimethamine 25 mg per tablet, and Malarone, atovaquone 250 mg plus proguanil 100 mg. Chemoprophylaxis, clinical uses, it is used in chemoprophylaxis, chloroquine 500 mg weekly and proguanil 200 mg daily. Maloprim, which is barimethamine plus sulfone-dapsone. Intermittent preventive therapy, amodiaquine plus sulfadoxine paramethine in the Sahel sub-region of Africa, which is used in the case of intermittent preventive therapy. And it's also used for the treatment of chloroquine-resistant falciparum malaria, like Fansidar sulfadoxine plus pyrimethamine, artesunate plus sulfadoxine pyrimethamine. In case of toxoplasmosis, pyrimethamine plus sulfadiazine is used, and in cases of pneumocystosis, trimethoprim plus sulfamethoxazole is used. Now the next drug is artemisinin. Derivatives are the most novel and recently introduced, now highly recommended. Its chemistry is that it is artemisinin is lactone endoperoxide. Semi-synthetic derivatives include artesunate, which is hemisuccinate salt of dihydroartemisinin, water-soluble given oral, IV, IM, or even rectally. Next semi-synthetic derivative is artemether, which is oil-soluble given orally. Next derivative is arteethyl, which is ethyl ether of dihydroartemisinin. Next derivative is dihydroartemisinin, which is reduced from water-soluble oral preparation. Now, its mechanism of action. Heme interacts with endoperoxide bridge in artemisinin, and when heme interacts with the endoperoxide bridge in artemisinin, it will release free radicals. That free radicals bind with membrane protein, cause lipid peroxidation, which will damage the endoplasmic reticulum and inhibit the protein synthesis, which will result in lysis in the parasite. Now, the clinical uses of artemisinin is that it is a rapidly acting blood schizonticidal agent. It is used in uncomplicated Plasmodium falciparum malaria, in case of complicated Plasmodium falciparum malaria, in severe cerebral malaria, and chloroquine-resistant falciparum malaria, and multi-drug-resistant falciparum malaria. Adverse effect highly safe during a drug otherwise. Adverse effects include nausea, vomiting, diarrhea. Few studies indicate cardiac problems. Some CNS manifestations include severe psychosis may occur. Safely given to the patients glucose 6-phosphate dehydrogenase deficient patients, as hemolytic anemia seen with conventional anti-malaria is not seen with this drug. It is also safe in case of children. Now the artemisinin based combination therapy. WHO recommends for the treatment of falciparum malaria in combination therapy like artesunate, amodiaquine, combination of artesunate and mefloquine, combination of artemether and lumefantrine, combination of artesunate and sulfadoxine pyrimethamine. Why combination therapy? Rapid clinical and parasitological cure, high cure rates and low relapse rate, there is absence of resistance and good tolerability profile. Now this is your assignment, mechanism of action of chloroquine and clinical uses of chloroquine. Please submit the assignment on time. Now Chemoprophylaxis of malaria. The drugs. Now I will summarize the drugs which are used for different purposes of malaria, and that topic is little bit tough for you people. So please listen to it carefully and read from the book, pharmacology book Travers, and read thoroughly. If there is any difficulty, you people can ask from me. For chemoprophylaxis of malaria, the drugs which are used for chloroquine sensitive area, but it is only used for prophylaxis. For in case of chloroquine sensitive area, chloroquine 150 milligram base is used 2 tab per week, and chloroquine resistant area, chloroquine 2 tab per week plus proguanil 100 milligram 1 or 2 tab per day, or mefloquine 250 milligram 1 tab per week. Now, treatment of malaria, chloroquine-sensitive Plasmodium falciparum and Plasmodium malaria infections, chloroquine phosphate 1 gram followed by 500 milligram at 6, 24 and 48 hours should be given. For Plasmodium vivax and Plasmodium ovale infections, chloroquine, then if glucose 6-phosphate normal, in case if there is not the deficiency of glucose 6-phosphate dehydrogenase, then primaquine can be given for 14 days. And in case of uncomplicated chloroquine resistance Plasmodium falciparum malaria, uh, coartem, which is a combination of RT method 20 mg plus lumefantrine 120 mg, 4 tablets twice daily for 3 days. In case of severe or complicated infections with P. falciparum, artesunate 2.4 mg per kg IV every 12 hours for 1 day, then daily for 2 additional days, follow with 7-day oral course of doxycycline or clindamycin, or full treatment course of coartem, malarone, mefloquine or quinidine gluconate, 4, 5 and 10 mg per kg IV over 1 to 2 hours, then 0.02 mg per kg IV per minute. In case of pregnant women for uncomplicated malaria, chloroquine in chloroquine-sensitive cases, quinine alone or with in combination with clindamycin in chloroquine-resistant cases, mefloquine in chloroquine-resistant cases. In first trimester, IV quinine alone or with clindamycin or IV artesunate can be used. Second and third trimester, IV artesunate can be used. In case of lactating mothers, chloroquine and hydroxychloroquine are preferred agents.